there's a reason why I left Debbie for last is, basically she is the evaluator and Mathematica is the evaluator for a lot of the CMS demonstrations. So with that, she gets the last word.
Thank you, Jerry. Everyone, I feel like should stretch a little bit, twist around. It's an honor to speak with you today. I'll be discussing my thoughts based in part on 2 large-scale studies we did for CMS, but I do have the disclaimer here that I'm not speaking on behalf of CMS or HHS. Let me first give you the punchlines of my presentation. First, as Lisa was saying and other people said, it is not easy to change and to improve outcomes. Providers we speak to report that it takes 1.5 years or longer for interventions to really click. Second, we have evidence that some models can improve outcomes for some patients. When Jerry told me which slot I was in, I said, I don't have anything to say. Everything we look at doesn't work, unfortunately. We haven't taken the next step to dissemination. And then I thought more about the lessons that we do have, which I'll talk about. We need more work, I think, to distill which models to scale, what are the key program features, what are successful targeting criteria, and what supports providers need. John and Raj mentioned some of these: data feedback, technical assistance, and of course, money. Money is important to get people's attention and to get the right resources that they need. We also know some factors that can help scale models, and I'm building these lessons learned on just 1 year of delivering an intervention to nearly 500 practices. So Lisa has seen it all too. Substantial financial incentives, multi-payer support, if the payers coordinate and align funding. Rebecca, you discussed the challenges of uncoordinated multi-payer activity. Adaptation of data and TA to reflect considerable diversity of practices, health systems, markets, and the patients that the practices are serving. And I guess the guardrails that Lisa spoke about are what is needed when monitoring or auditing a program if the funders are bearing a risk, not the providers, to ensure the programs are implemented as intended. Okay, let me turn to some specifics. We know patient targeting matters. We did an evaluation of the Medicare coordinated care demonstration, which was care management provided externally, so not the embedded care managers that really the field has moved on to. But we found that more programs were successful when we looked at their higher risk patients. They were all serving high risk patients to begin with, but having prior utilization and a chronic condition to define high risk, which was the best we could do using claims data. So targeting does matter. The devil is in the details of these models. I'm just looking at one aspect of the programs. All 11 programs we looked at in the demonstration provided medication management, but the 4 that were more successful for their high-risk patients did it very thoroughly. They didn't just ask patients to self-report what medications they were taking. They did things like having them bring in a bag of their medications or talking to multiple specialists and figuring out what they were prescribed. They also had access to pharmacists or a medical director. We could go through each component of the model and tell you that the more successful programs did it differently. Okay, I should also point out that even having a successful program doesn't guarantee continued success over time. In that demonstration, the most successful program was extended by CMS. It did make slight tweaks to how it recruited patients. It moved into adjacent areas, still a demographically similar population to what it was serving, and the effects went away. We're still trying to sort out why, but it's just an important, and it is an extremely well-run, data-driven, thoughtful learning organization kind of program. So it just reinforces the point that we need really to figure out what models work. Okay, let me now turn to this slide, which is early lessons about scaling and intervention. And as I said, I have not seen interventions disseminated, but what we did see is in the Comprehensive Primary Care Initiative is a large-scale intervention. Nearly 500 practices getting an intervention this big off the ground in 7 regions with over 2,000 clinicians is a huge undertaking. We've only had effects through the first year, and as I said before, we don't really expect to find favorable effects that soon. We did see what appear to be favorable effects. We want to be cautious. It's early to expect changes, and we need more data to confirm the favorable findings. But nonetheless, I think just watching this program get off the ground in this first year has brought us many lessons for spreading interventions when I thought about it, what I was going to say today. The first is strong, understandable financial incentives help gain traction with providers. Payment has to be substantial. It has to affect a sizable share of practices' patients to get busy providers' attention. Sorry, I should go back. CPC is basically a medical home-like intervention. At its core is risk-stratified care management, but there are other aspects of care that are changing from patient engagement to access. Multi-payer support, CMS partnered with Medicaid and 29 private payers, made this really attractive to the payers and the practices. The total CPC payment to the median practice in the first year was $226,000. That works out to be $70,000 per clinician, or nearly 20% of total practice revenue. So this is real money on the table. There's been minimal attrition so far, and let me tell you, the transformational requirements, the reporting requirements are steep. Melinda spoke earlier about amenability to change, and I want to point out that when we think about spreading things, we need to think about amenability to change of systems, of practices, of providers, of staff, and of patients. One thing we have noticed is that in some of the systems, it's been really hard to move the intervention down to the practices. Either they hold the money and don't push it, don't give those resources to the practices. Sometimes they don't let the TA providers interact with the practices, et cetera. So another thing that we have to think about when tailoring an intervention is the terrain that it's getting disseminated to is very varied. To motivate practices, shared savings have to be understandable, linked to actions and changes, and paid relatively soon after improvement. Practices are very worried about sustainability after the funding ends, and in particular, they're most worried about how they're going to be able to provide care management and quality improvement, because neither of those is really fully compensated in the current system. Okay, so let's turn to some considerations for data feedback. And the Care First speaker spoke about this as well. We think providers do need regular feedback. Most providers have no idea what happens, what kind of services their patients go to outside of their practice unless the patients tell them, so they don't get consistent feedback. CPC provides data feedback about claims data, utilization, some quality of care measures, but also patient experience and practice reported primary care functioning, and they see how they're doing relative to other practices participating, which is a big motivator. They get patient level data to allow practices to drill down. So that feedback can fuel quality improvement, but there are two caveats. The first is that the feedback for quality improvement often focuses on trends without a rigorous comparison group, and we do worry that sometimes we are probably giving practices the wrong signals, because there are different inferences in an evaluation estimates. The other factor is that practices really want rapid cycle QI, particularly with ER and hospitalization use. You know, the researchers want more time for claims run out. It takes time to process the data, make sure it's accurate, and cost of giving those reports. So it's sort of balancing those two things. The third, which I should have put up here, is, I think it comes later in the slide deck, a lot of practices have no idea what to do with this data. They don't understand the rate. They don't understand rates. They don't understand what's actionable, what the heck to do with it. You know, in the beginning of CPC, a lot of the practices didn't even open the data. And it took probably 6 months to a year for some of them to realize that there were Excel files that they could actually look at patients, you know. So, and some of them are very sophisticated. So it's a real varied terrain again. The practices really want specialist cost and quality data to guide referrals, and you spoke about that earlier, and why you said we'd have to have a beer to hear the politics behind it. We, on behalf of CMS, cannot provide that data. I think there's a lot of concerns about whether the data is risk adjusted and appropriate, and how to measure not just cost but value, you know, the quality as well of those specialists. They want comparisons of their own outcomes to those of similar practices. Now, the challenge for us is that some want a rural practice, some want a small practice, some want, you know, the various combinations that they want would require a lot of resources. Of course, less is more. Information overload can lead to no action if they get too many measures, And if they get unaligned feedback from multiple plans at different times with different outcome measures, different denominators, it's very confusing. And I did have it. Many practices need TA to interpret and act on the data. It's practices, it's systems. They vary in their data orientation. They vary in their sophistication. In some cases, they don't know what is actionable, and in some cases, not everything is actionable. Okay, so the third component of CPC was providing technical assistance and collaborative learning networks. What we've learned from that first year is that I think there's a lot of reticence on people who run programs to be too prescriptive and tell a practice what to do, but the practices are saying, tell us, we have no idea what to do. Money is not enough. They need help. They need step-by-step instructions, tools, and resources, not all of them. So I think, you know, a WISE program is going to provide very specific tactics, and practices and systems that have a better idea of what they're going to do don't need to use them, but a lot of them do need it. To be nimble and responsive to the practice needs, CMS saw that a lot of the practices were having trouble getting any information out of their EHR. They're a one-way trap, and they set up EHR affinity groups and invited EHR vendors along, and that was, the practices are reporting that to be very helpful to them. Tailoring the TA, the practices needs vary very widely based on how they were providing primary care in the first place, system versus independent, rural versus urban, the medical neighborhood they're in, their patients, et cetera. Resource constraints. Almost every practice would prefer someone come to their practice and tailor TA to them, but it's very costly for a program to provide that. And so, you know, while webinars aren't very popular, they're very didactic and a little bit boring, and we've all been there and multitasked during a webinar. It can be, you know, someone who's delivering a program has to figure out how to combine these, how to triage scarce TA resources to the practices in need, and how to set up some webinars to cover some of the more basic level setting information. Peer learning and networking is very important, and practices rave about it, but the TA providers have said in some cases it's been very hard to find exemplars and to find exemplars who have the time to put together a presentation and to spread that information. So it doesn't just happen. Something we learned both from the CMS work and from some work we did for ARC was the importance of teaching leadership and teamwork. Practices that spread the work across the entire practice team in the first year of the CPC were much more successful in implementing it. Otherwise, there's too much burden on the clinician champion, lack of a learning organization culture, and unclear roles and responsibilities. Okay, I'm going to now share some general thoughts, really questions about scaling. I guess this is, you know, something to think about for the next 2 workshops maybe. But how do we recruit systems, practices, and patients? All this stuff is very specific to the particular intervention that we're thinking about scaling. I'm sure everyone in the room probably has different ideas in their head of what they would want to scale. But how large does the financial incentive need to be? How hard can the reporting requirements be for the providers? How will the model fit with other efforts and initiatives providers may participate? This is something I am thinking about very deeply, is how do you counteract the incentives to cherry pick or drop patients or stint on care when you start putting some skin in the game, some shared savings for providers? And we're hearing anecdotal evidence of this, you know, in literature reviews I'm doing and things. And, you know, I don't have an answer here, but I think we need to think about it, especially when there are binary measures of quality of care. Providers say, from some commercial programs, why, if I can reduce HbA1cs from 12 to 10, but the cutoff's 9, I get no credit. I don't want that patient on my rolls. I don't want it to be counted against me. How to encourage more services to be deployed to high-risk patients in models like the medical home, where we believe that all patients should be covered, but that you want to incentivize people to focus most of their resources on the higher risk patients. And how can an intervention be adapted for different contexts, and how will it affect outcomes when the leadership changes? If you find a successful, without Bob Masters, how does that model move to a different leader, different staff, different market, and different patient mix? And finally, how to monitor a scaled program. If providers aren't bearing risk, Monitoring or auditing can make sure that the funder is getting what they're paying for. Monitoring will require management information systems or data reporting, require some knowledge of the guardrails, those key components of the model, and ways to document its delivery. Auditing may be less costly, but some funders may be less comfortable with less control. Just to thank you for the support for these studies from CMS, the Robert Wood Johnson HCFO program, and the Medicare Chronic Care Practice Research Network.
So I'd like to thank the entire panel. You did a great job, both timing and substance.